Welcome to this edition of AFMC.
I'll tell you how I got better. I'm
Glad to be here.
But a mission to
Delivery of
improve.
I think that we're going to talk about everybody's.
Arkansas is the second highest prescriber.
Welcome to AFMC TV. I'm Robin Ledbetter. Thank you for joining us. Today I have with me Dr. Singh. He is a hematologist and oncologist with the UAMS Winthrop Rockefeller Cancer Institute and the director for the Sickle Cell Clinic at UAMS. Dr. Singh, thank you so much for joining us.
Thank you for having me here.
So tell us a little bit about your work at UAMS.
Sure. So I see sickle cell patients in our comprehensive sickle cell clinic, where we have a multidisciplinary team. So usually we will see patients in the morning, and also we have some slots in the afternoon, and we address all their issues pertaining to sickle cell issues, which includes management of pain, sickle cell disease, and then referring them to the appropriate specialists if and when the need arises.
And is sickle cell super prevalent in Arkansas? What are you seeing?
Yeah, we have a pretty large population for the size of the state as far as sickle cell disease is concerned. It's a disorder of the hemoglobin of the red blood cell, and it's inherited. And the majority of the patients are African American. We do see some of our patients being of Hispanic origin, but yeah, we have a big sickle cell population.
And there have been some recent advancements in sickle cell treatment. Are you seeing that in your clinic?
Yes. So over the past few years, we've seen rapid advancements and growth in the field. So there have been approvals of newer therapies. So initially, we only had hydria and folic acid as an option, and then FDA approved in 2018-19 voxelotor and crizanlizumab. These were two additional medication, and then we also had Endari. That's another medication that was approved. And the latest and the hottest topic in sickle cell is definitely gene therapy, which just got approved barely a few weeks ago. We don't have it yet at UAMS. It's a big logistical a process that we have to really put into place so that we are able to offer it. And I'm hoping by the end of this year we're able to offer it at UAMS.
And what does that entail, and why is it the process so complicated?
Sure. So gene therapy is basically a form of stem cell transplant, where we take the patient's stem cells, we collect stem cells, and then we send it to a company which specializes in using certain viral vectors and certain other technologies by which they make changes to the gene of the cells which we got from the patient. Now, these changes are aimed at either correcting the defect which led to sickle cell disease in its first place, or making changes in the genome which help us in a way to counteract the effects of sickle cell disease. So that process is highly specialized because these companies are working at the molecular level. And once those changes have been made, those cells are sent back to the institution from where the patient is being seen. Patient is then admitted to the hospital. We give them high dose chemotherapy, and that is to basically wipe out their bone marrow, which has the defective cells. And once that is done, we reinfuse the patient's corrected blood cells and let them find home in the patient's bone marrow. And all of this takes time because the patient has to be admitted to the hospital. And then once this whole process has been completed, we expect that people should not have these problems that they were having because of having sickle cell disease, because now they have their gene has essentially been edited in the right way.
Wow, that sounds incredible. Is that something how soon do you think that would be happening here? Are you expecting to be able to do that here?
I'm hoping that we are able to bring it and start it by the end of this year. Because it's not just the FDA approval, but this is a very expensive treatment option that has been made available. So currently, the price of the gene therapy is around $2.2 million. And that's really expensive in the sense that we need to convince the government, the Medicaid, and all the insurance companies to partner with us to be able to successfully do this. And that is probably the biggest I think challenge that all institutions will face across the country is the price of this therapy. But I expect that with time, and that's the case with medicine in general. These therapies, they start to become less and less expensive as more and more people start offering it. So I think with time it will become financially less of an issue. But right now, I think that's the major hoop that we have to jump.
And is it available for anyone with sickle cell, or is it a specific type?
So the approval for so the approval is for sickle cell disease patients. Does not matter, if they've tried other medications or not. But I think all institutions will have protocols in place because to decide, who should this be offered to first, because there are patients who are not doing well on the current therapies, are really suffering a lot. And so we may have algorithms and decision making pathways by which we kind of decide, okay, this is the patient who we need to kind of prioritize, because this patient is just nothing's working for this patient. So that's gene therapy is the only thing that will work. So that's probably how it'll play out. But we'll have to wait and see. But the approval is for all patients, and that's actually really good. It gives us a lot of flexibility, as to pivot based on how things pan out.
It sounds like potential to make a drastic change in treatment long term for anyone. It's incredible.
Definitely. So in the trials, the results were really encouraging because the patients who underwent the gene therapy, they did not have vaso-occlusive crisis, and that's the term that is given to the complication of sickle cell that causes the patients to end up in the hospital again and again, vaso-occlusive crisis. So it had a really good improvement in that pain control and hemoglobin levels. So in overall, it seems to work really well. And even though the data is not mature in terms of, we don't have data for 10 years or so, it's only a few years of data. But despite that, what we've seen so far, that the effect of the treatment continues. It does not wear off, and that's expected.
Let's switch gears for just a minute and tell me a little bit about pregnancy and sickle cell. Do you have a lot of patients that are expecting and have sickle cell?
We do have a few patients who have sickle cell disease and are pregnant, and I would like to use this forum to really put it out there for all our patients and physicians and nurses who are taking care of sickle cell patients, that pregnancy is perhaps one of the trickiest times in a female patient who has sickle cell disease. There is definite concrete data to show that pregnant sickle cell patients have higher mortality rates, and not just themselves, but also for the fetus, because sickle cell disease many times flares up during pregnancy. And most of the therapies that we have, actually, all the 3 medications or 4 medications that I mentioned about, they were never tested in pregnant women. So we end up stopping those medications. We don't know if it will harm the baby. So for a patient who was on those treatments and now is pregnant, and now who cannot take those medications, obviously the symptom burden goes up, the disease starts to act up. And not just that, but there's increased risk of blood clots. So things can get really complicated sometimes, and that is well documented, well reported. So it's always it's good to be educated and know what to expect for a female sickle cell patient when they're planning to start a family.
So they should be followed very close and monitored closely and considered high risk?
That is true. So we partner with our high risk OB/GYN colleagues, so who have experience in treating pregnant sickle cell patients. So it's a collaborative management, and yes, these patients need to be monitored very closely.
What is the usual presentation for sickle cell?
So the most common presentation is pain. Majority of our patients basically have pain throughout their lives, unfortunately, and they try to control all they can at home, and when that's not happening, they have to go to the ER, and primarily for IV pain medications. And so that is what forms the bulk. In addition to that, there are other complications that the patients could present with, such as acute chest syndrome, where they might have respiratory failure. Sometimes they could have infarcts in a particular body part, which means loss of blood supply because of the sickle cells actually causing reduction in blood supply to particular parts. Strokes, these are more acute presentations, but chronically we do see other issues such as loss of vision that can happen, kidney issues, and then because they end up getting a lot of blood when they go to the hospital. Some of these patients also develop iron overload, and that iron overload can cause issues to their kidneys and to their liver and heart. So a lot of symptoms and signs to watch out for.
And those are vital for an ER physician when they come in through the ER too. Is there anything specific that you think those physicians should look for that make a difference?
Definitely. So I think my humble request to all first line frontline physicians and nurses is to probably err on the side of believing what the patient is saying, because what happens with a lot of sickle cell patients is they have lived so long since their childhood memory. They know for sure one thing is that is pain. So they know very well how to cope with pain. So for them, if they're having 8 out of 10 or 9 out of 10 pain, it's possible for them to be sitting on the stretcher and yet be using their phone because they are so used to living in so much pain. But to someone who does not know that background, it may appear as if the patient is over-reporting the pain. So one of my patients told me that it's not fun for them to go to the ER to get pain medication because the average wait time to even get the first medication is several hours. So majority of the patients are not coming to the ER just to get pain medications. They're not drug seeking. But we do have patients who do have issues with opioids. That we all of us are aware of that. But I think what happens is that perception ends up being generalized on all sickle cell patients, and that ends up causing these sickle cell patients to have a really terrible experience when they come to the hospital, because a lot of times they feel that they're being judged or people are not believing what they're saying. So that is something that I think we as a community, healthcare community, need to identify within ourselves and probably err on the side of believing what they're saying.
So then that's just one of the stigmas that's around sickle cell that you see?
I think that is the biggest stigma that we see, is that they're pain seeking and all they want is pain medications. And then the other issue is a lot of our patients, because of having chronic pain, are actually that translates to a poorer socioeconomic status. They're not able to get or hold on to jobs because they end up going to the hospital so many times. So they get fired or they're just not eligible for some jobs. So it's a vicious cycle they get caught in, and then they might lose their insurance or then may miss days at work, or then so it's just too complicated for them sometimes. So, and the answer to that is basically having a system in place where we are able to address the pain in a proactive manner, so that we are able to get them back into the workforce and getting them the access to all the latest therapies that we can offer.
Well, Dr. Singh, I've learned a lot today, and I appreciate all that you do at your clinic and through research. And it sounds like you're at the forefront of research and therapy. So thank you.
You're welcome.
And that's it for this episode of AFMC TV. Thanks for watching, and have a great day.